where are we now? We are in a very comfortable yet very difficult position. We've had genuinely massive increase in health spending. We spend a lot of our budget on health, and within that, we spend a lot of our budget on mental health. So whenever people say that we are a Cinderella service, I'd say go back and look at the figures, and you might find that we actually do quite well in mental health. But that's going to come to an end. Whichever party wins the election, it's going to come to an end, no matter what they say. The budget will be cut. And so our world-class commissioning will depend upon decommissioning. We will have to do fewer things. And the parameters by which whether a service is funded or not have been clearly defined. It's the quality as defined in Dardi review, which is clinical effectiveness, safety and patient experience, and it is productivity. And no matter how much you like or dislike cost economic analysis, it is here to stay. The public purse has to be justified, how we spend that money. And there are going to be key measures. And that's going to be one of the challenges for you, to demonstrate that the investment in IAPT is worth the returns. And we will have to do more with less resources. This is where I think we are heading. We are heading towards increasing functionalization in secondary care. So there are going to be increasing specializations and smaller teams doing intensive, focused work. The disadvantage will be that there will be a lot of transitions between teams. So the patient experience bit may suffer, as continuity gets fragmented, and that's a challenge for secondary care services. CMHTs have had their day. They will have to be leaner and more efficient. And most importantly, for the third sector and voluntary bodies, here's your chance. You can now compete with IAPT type services will be competed for. I have no reason to believe that I can provide IAPT service better than someone else. So if I'm a chief executive of a mental health trust, I have a problem. A lot of my business can be taken away. And I think in the primary care, you are going to get this local enhanced service model where GPs will take on some more work with mental health conditions that traditionally have been with secondary care. I've already said that the third sector will have an increasing role, rightfully so. They do a lot of things very well, much better than the NHS. And to do all of this, and the commissioning will be strengthened. The power will move to commissioners to buy. And commissioners will buy using the parameters that I've told you. Quality and productivity. And those are the challenges that you need to take away as well. You all use a stepped care model. And I think we will see more of that along the route. But I think for stepped care model to work, just like for the Yorkshire model to work, you have to be very, very sure that the person is at the right step. One of your poorer outcomes, I would go back and look at that carefully. Are people getting low intensity treatment when they need low intensity, or are some of them wrongly getting low intensity treatment which should be elsewhere? So the stepped care model must have an oversight by skilled clinicians. That's how it's going to work. Otherwise you have a problem of people being placed in the wrong step. So these are your obstacles and really your opportunities. The New Horizons document very clearly states that we should be thinking much more about upstream prevention and health promotion. And that's where you really come into your own. That's where IAPT, that it's best. You can help people in the early stages of developing distress, and you may be able to stop things progressing. Just like any illness, you have stages. If you take cancer, you have earlier stages. The quicker you diagnose, the more efficacious the treatments, the safer the treatments, the better the outcome. There's no reason why that model doesn't apply to mental health services. And IAPT could be very useful in preventive strategies. I think, again, this is already happening. We are thinking much more than just symptom control. We are thinking of functional improvement. So it's not just I'm feeling less anxious, but I'm feeling less anxious so I can go to work, or I can fulfill my role as a spouse or a mother or a father. We've got to embed IAPT within services, especially within communities, I beg your pardon, especially within communities which have traditionally not taken psychological therapies as part of how they see treatment. I specifically refer to Black and minority ethnic groups. We've got to be very careful that IAPT doesn't become an Edgbaston service and not a Spark Hill service. And the services have to be socially inclusive in more than just the patients, but even in the population that provides the service. For you to do this, I'm very glad to see the workshops and training programs that Jerry referred to. We need a workforce that is skilled to do this. And I come back to my stepped care model. What you don't want is someone with emerging psychosis who's prominently complaining of anxiety, stuck in a low-intensity work. We are looking at data from Birmingham, and what we found is that young people who become psychotic but come to the services before they are psychotic have very long delays in treatment, and which is quite a shocking indictment. They become unwell. They go from being depressed to being psychotic while under the care of mental health services and don't get picked up. That's because the original diagnosis sticks. You say, well, this is all part of the depression. Now, if IAPT has one or two of these scandals, some untoward incident, you've got to be very careful that you get your patients at the right step. And that requires skills. That requires, you should not see psychotherapy as just by itself complete. It's got to be part of the larger mental health picture. So you've got to have a larger set of assessment skills than are needed for delivering. I hope I'm making sense. It's a very important point, and I think it's a challenge for you. But I'm sure you will rise to the challenge. I think I was in Denmark a little while back, and a professor over there said, well, you are lucky in England, you've got your psychological services sorted. And that's the other risk of thinking that our psychological services are sorted. This is a start. Okay, and when the economic climate turns sour, you've got to be able to say, we are actually quite useful and quite effective, and this is high quality. So it's the beginning of a process. This is not the end. And I just put this up. The creature on the left is a juvenile sea squirt, and it has a rudimentary brain, which it uses to find a place to attach itself. It finds a rock and grows into that particular species, and then it eats the brain because it no longer needs it. And people say, well, professors are like that. You find a chair in an academic department, you never use it. And there is a danger of finding a place to park yourself and feeling comfortable. This is a start for you. And as you start, the other metaphor I like about change is from riding. If you're riding, after a while, a bit of your bottom hurts, and you change your position, and you find comfort in that, but it starts hurting elsewhere. Now, as we make all these service changes, we'll get some things right. There'll be relief somewhere, but other bits will hurt. And so what we want to do is maximize the relief and minimize the hurt. And that's your ultimate challenge. So thank you very much for inviting me. I'm sorry I can't stay. I wish you all the success. Thank you very much.